Well, all right. In the interest of time, let's go ahead and get started. Good afternoon and welcome to today's webinar. It's hosted by the Georgia chapter of HFMA. I'm Lorie and I'm a Georgia HFMA Education Committee volunteer. I want to give you some reminders about activities before we close out the year. Top on the list is our virtual Give Back Challenge. There's a final virtual giving weekend this Friday and Saturday, December 11th and 12th. Rather than being in person, we ask that you be creative in ways that you can give back to the community and then document that on our Georgia HFMA social channels with the hashtag HFMA gives back exclamation point. Don't forget the exclamation point. Some ideas include dropping off monetary gift cards to the local shelter or food bank. You can organize a neighborhood food drive for the holidays, or even buy a cup of coffee for the person behind you in the line at Starbucks. Also, on that theme of giving, just want to remind you guys that the Georgia HFMA is still looking for volunteers for our various committees. Even in the virtual environment, we are staying connected with our membership. And this is a great way to network and remain involved in the industry. So please take a moment to check out the committees that we have and please raise your hand to volunteer. And you can do that by going to the Georgia HFMA website and checking it out under the Get Involved tab. And then lastly, we produced a ton of great education last month for the Virtual Fall Institute. Again, you can check it out on the Georgia HFMA website. Here are a few housekeeping items. All of the phone lines are going to be on mute to avoid interruptions during the broadcast. Please do submit your questions via the question box at any time, and I'll coordinate with our presenters and panelists for their answers. You can, and then we will be down, you will have a download for the presentation on the Georgia HFMA website, along with the recording. And I'll be sending those two items as well as the CPE credit form via email on Friday. So be on the lookout for that. The email will come from me, Lorie. And as I was mentioning, so everybody on today's call is eligible to receive continuing education credit. And again, just be on the lookout for that form in the email. You'll be able to self-submit it to get your credit on the Georgia, I'm sorry, not on the Georgia, on the National HFMA website under the membership info tab. Finally, I'd like to take a second to recognize and thank our chapter sponsors. Tom, if you wouldn't mind just flipping to that screen real quickly. You can see the logos on the screen here. And again, thank you so much for your support. Today's session, Leveraging Your Physician Advisor, it's going to be a panel discussion today featuring features from the Alliance HIM, FairCode, and Forrest Health. I'll introduce our panel moderator, Tom Mary, and he will then introduce the panelists for today. Tom is president and founder of Alliance HIM, with over 25 years experience designing and developing documented data management solutions. Tom is a resource for hospitals to help identify and partner with vendors in the revenue cycle and HIM space. Tom has held positions ranging from customer service up to general manager with P&L responsibilities for multiple locations, and he now represents 5 small but outstanding companies in a sales and marketing role. Additionally, Tom's experience as a Six Sigma Black Belt has reinforced his expertise in analyzing and delivering accurate data and reporting tools. So Tom, I'll turn it over to you. We're ready to begin.
Thank you, Lorie. Thanks everybody for joining. Wow, that bio actually impresses me. If I didn't know any better, I'd be impressed. Thank you. Thanks everybody for joining in this difficult time, and COVID's raging back again. So hope everybody is safe, and best wishes for a safe and happy holiday. Definitely want to get that through. I'm real excited to introduce our speakers today and kind of host and sort of moderate this conversation. Since it's mostly a panel discussion, you may want to kind of split screen and get the panelists, visual in there. But it'll be kind of a conversation. We do have a couple of case studies that we'll get to kind of in the middle to really discuss the numbers that can be affected by a physician advisor program and different ways of leveraging a physician advisor. So we'll get to that soon. So everybody in the healthcare space is aware that documentation is a challenge. It's difficult if you've got a large and mature CDI program, and those of you that are still more on the beginning stages of that journey know it's even a greater challenge. but the bottom line is it is really challenging. And physician advisors and champions are really part of that solution, and maybe one of the key parts of that solution. So today's discussion is kind of helping us think through the barriers to getting that information to colleagues and throughout your institutions. So we're going to explore that. Many hospitals use their advisors to improve their goals, whether it be clinical, quality, and financial. We're going to talk to a couple of physician champions from Forrest Health. We've got an HIM expert and a leader of a outsourced solution provider in the CDI space. So I'm excited to introduce this group, and I think you'll enjoy the conversation. Please do put some questions in the chat box. We hope to get to a good amount of time for that at the end. So our first panelist is Lorie Mills, and she is a System Director of Coding and Clinical Documentation at Forrest Health. I won't go through reading the entire thing, but do want to point out she is an extremely active participant in AHIMA, particularly in Mississippi HIMA. She's been on the board of directors for 11 years, served on many of their committees, third term as president. So she gives back, and I know she gets a lot out of these associations. So very, very excited to have her here today. I also definitely want to point out she's been published and co-authored the article for Red Flags for Myocardial Infarctions, Coding in CDI. And I know she's real proud of the work she did with the American College of Cardiology to develop education for type 2 MIs. And with that being said, it's a shame that we don't get to see her shoes today. I know that she's very proud of her shoes. But let me stop and just start, Lorie, asking, can you tell us a little bit about how you engage your medical staff at Forrest Health and how they've helped improve your clinical documentation? Oh, you're on mute.
It's great to be here with you people from Georgia today. I'm looking forward to this conversation. So to answer your question, Tom, we develop our relationships with our medical staff in many ways. A lot of that is based on face-to-face interaction. We have currently started a program for orientation of new staff members that they rotate through our department as part of their orientation to meet our CDI team. We go and give them tip cards that we have already completed. We discuss documentation, we discuss queries, what they can expect, how often they can expect to see us rounding on the floor. We actually go to some department meetings. We set up time to go and speak to different groups for documentation improvement. One of the key things that we do is we identify who our physician champions are, and we become close to those people. For instance, Dr. Donald is one of my physician champions, and he has been very helpful. And I think that part of that is due to the relationship that we have, that my group has built with him. He knows that if I reach out to him that, I really do need his help. I've done everything or exhausted the things that I can do from my own, that I need some intervention other than what I can offer from just my department. We actually look at our physicians and decide what kind of education is best for them. Are they the kind of physician that I can go to and do face-to-face 5-minute sessions with on the floor? Or is it somebody that it's just best to hand them a tip card, say, please call me if you have any questions? Sometimes they do, sometimes they don't. They just don't like that interaction face-to-face with the CDI staff. And we've learned who we can approach and who we need to just, give the information to. The other thing is we've developed a really close relationship with our CMO, and he's very engaged, and he's had us come to his hospitalist department meeting and have conversations. When we have issues with providers giving, query responses that are not actually appropriate, we are able to reach out to them, and those physicians will go and talk to them for us. Another thing we do is we use DMA Dragon Medical Assist to help some of our providers, and that's kind of a new thing to prompt them on documentation. So we're not sure exactly how well that's going to work yet. I do see that we'll still need that interpersonal CDI relationship with our medical staff.
Thank you, Lorie. It's interesting, the profiling people's personalities and how to approach them. It sounds like a sales kind of training, but it goes through every position in every company. You know, we need to deal with that. So my next introduction, I would like to introduce Lisa Boyce. She's president and co-founder of FairCode Associates. And she's got 25 years experience in the hospital and ancillary healthcare services as a nurse. So that gives her some clinical background here. Clinical operations administrator and managed care professional. Lisa brings significant knowledge of CDI operations, service line marketing, financial performance, and physician recruitment and retention strategies. And her company, FairCode, if you haven't heard of FairCode, by the way, I'm proud to represent them for almost 4 years now. They use predictive analytics to determine the charts that a physician should be deployed to review. So a physician who's been trained in coding to review charts that have been selected through analytics. And this is all done pre-bill. The FairCode physician advisors, specially trained in coding so they can speak the language. And not only do they ensure the correct DRG is selected, but they're also writing queries. So it's a peer-to-peer response or peer-to-peer communication with our client attendings. Prior to FairCode, Lisa served in varying capacities for hospitals, for health system outpatient and ambulatory subsidiaries, for MCOs, and for physician organizations in the Mid-Atlantic region. And her consulting work for payers and providers has led to successful programs in the areas of clinical product development, quality management, and cost containment. And Lisa has a BS in nursing, as I mentioned, and an MBA from the College of William and Mary. And I'm very, very proud to say a good friend of mine. Lisa, from your experience, and you've got so many customers, so you can really look at this from a wider view maybe than some of us. How can a hospital engage the medical staff to improve financial and quality reporting?
Thanks so much. I do think that it is, building on what Lorie said, an opportunity to take advantage of the high touch approach that CDI has. In COVID days, that has been a real challenge for our CDI departments. But I do think that managing and leveraging those personal relationships is going to be helpful in creating that engagement. I think one of the most important things that we need to be doing is communicating to the medical staff what we're doing and why we're doing it. So, you know, is it a matter of our star ratings? Is it a matter of our Pepper reports? Is it a matter of us trying to get on the honor roll of the U.S. News and World Reports? Are we looking at readmissions? Are we trying to get certificate of need for certain services? Is this going after a bond rating? So by communicating sort of what is our mission and why we care about clinical documentation, I think is really important. I mentioned bond ratings because a lot of times in the CFO world, we don't think about saying to the medical staff, by the way, if we can boost our financial position, our cash position, we can then raise our ratings, which makes money cheaper, et cetera. So the argument then is tying it back to things that matter to the hospital. And sometimes we delude ourselves in thinking that our doctors don't care about that stuff. And in truth, by communicating about why we do what we do, I think we're going to be able to engage our medical staff in a way that is going to be meaningful when it comes to capturing clinical documentation for financial and quality performance. Because our doctors, and we have 120 of them who work at FairCode, respond to data. It's not unusual for me to start saying to you all who already know it, if you quantify what you're doing, if you quantify the impact, you can tell the doc, how much money are you leaving on the table? in real dollars. You can look at it by case, but you can also look at it across the board, across the medical staff. You can look at it by department. You can be, if you can quantify how much money is being left on the table, I think, again, you're speaking a language that physicians can hear because they understand data being science driven. And I think it's important to communicate about how much money we're leaving on the table. As you probably know, the clawbacks from payers has been really intense for clinical coding. Yes, we've always had medical necessity issues and relationships with payers need to be developed, but we've got a new twist in the market, and that is coming from denials for clinical coding. And we've really got to quantify that for our medical staff. We need to be engaging them in the approach to the payers in a way that says, hey, you know what? The clinical team spent a lot of time and energy taking care of the patient for certain diagnoses. No one wants to leave money on the table. If you're doing that kind of good work, you want to be paid for it, and your medical staff is going to appreciate that. I'm sure Lorie can tell you, and Dr. Donald, when he is able to, if I can stop talking and able to give him a chance to talk, can talk about what it means personally after you've given so much care to have a payer turn around and say, oh no, the patient wasn't that sick. I think also in terms of quality, if your quality report card isn't reflecting how sick your patients are, I think that will capture the medical staff's attention. So I wanted to give you a sort of a story that I heard from Dr. Fox of Cooper Health in New Jersey. She said one of the things that she's doing to engage the medical staff is to take advantage of some of the opportunities that exist today. For example, her anesthesia providers were rounding on patients in the MICU, and she took an opportunity for those providers who previously never documented in the chart and educated them about the importance of capturing their vent settings, dates and times of those intubations, so that that could be reflected in the codes that we are capturing for those vent patients that can make the difference of tens of thousands of dollars. She also said she engaged those same providers to actually accurately capture those procedures and those procedure notes for the ECMO treatments, so that, again, that became a real opportunity, particularly during COVID. And she used that building on the fact that those anesthesia providers were already doing the rounds. They just weren't doing the documentation that was necessary for the coders to capture vent times and ECMO procedures. I'm going to stop talking. Maybe we have some others who might be able to join the crowd here and talk a little bit more about engaging our medical staffs.
Well, thank you. And we're expecting Dr. Stogner shortly.
He's on. He's here.
Oh, is he on the call right now?
He is on the call.
Fantastic.
Unmute yourself, Dr. Stogner.
Dr. Stogner is...
I'm on. Hey.
All right. Specializes in pulmonary medicine and critical care medicine. Again, I'm not going to read through the details here. Everyone's got it. Dr. Stogner is a very credentialed and well-known and respected doctor, and also married to Emily with 3 children and 1 granddaughter and 1 grandson. So, Dr. Stogner, I'm very, very pleased to meet you, and thank you for joining us on this discussion.
Absolutely. Nice to meet you.
And as a physician champion, what are some of the strategies you see that facilitate better documentation amongst your colleagues?
Well, first of all, thank you, and thank you to Lorie for allowing me to participate with this. But you know, it's very important to have a physician champion. It's very important that physician champion develop a relationship with the physicians. And the reason I say that is there are opportunities to show specific examples of how the accuracy of documentation and thus coding shows what we are doing. Not only did we do the work, but it's a manner that it's very important to look at the metrics, our performance of how we're doing and taking care of specific disease categories. Without the documentation, we have no way of doing that. And we are absolutely in a world of going to even more value-based care. It's already in the outpatient setting and will become more mandatory. And I can see that as it's already proceeding in inpatient setting as well. So the documentation, whether people like it or not, is it's required. And I find that physicians are actually very receptive to learning how to do this accurately. And it's not very hard. It's not very hard at all. You just have to pay attention, and the physician champion has to be aware of and work closely with the coding team to know this so that they can pass it along to the physicians.
Mm-hmm. I'd like to jump in right here, Tom. I have a great example of what Dr. Stogner is talking about. We were getting some denials on some bronchoscopies a couple of years ago because the definition changed in ICD-10, and the docs clinically, what they were doing, they were saying what they were doing, but it wasn't matching the definition of what PCS said. So we took those denials to Dr. Stogner, and he actually wrote a very scathing appeals letter about it. But we also tweaked our templates on our bronchoscopies that would make the doc put that documentation in there, that it would cue him, hey, you've got to make sure you answer this. And so we've not seen any more denials on that. And that's one way we leverage our physicians is appeals, and also how do we tweak our EMR to make sure we're capturing what we need to capture.
Right.
Thank you, Lorie. I'm guessing denials is definitely a hot spot when you and your peers find out about those, huh, Dr. Stogner and Dr. Donald?
It is, and Dr. Donald can speak to this as well, but a lot of times the denials actually, well, there can be a number of reasons, but the denials are intricately related to the documentation. And if you can do that on the front end, it certainly decreases the resources necessary to combat it. And a process like Lorie's talking about it in the electronic health record absolutely resolves that issue on the front end. And once we know, that's the reason I was saying, like the physician champion, having some good working knowledge that's provided by Lorie's team and all on the front end, and getting the doctors on board, showing them the importance of that, you can alleviate a lot of the problems with denials on the front end.
True.
All right, and let's introduce Dr. Duncan Donald, Medical Director of Trauma Surgery at Forrest General, which, by the way, if anyone's not familiar, is a level 2 trauma center in Hattiesburg, Mississippi. And again, I'm not going to go through all the detail here, but as you can see, Dr. Donald has received awards in leadership, quality, and documentation. Wow, that fits in with our conversation. And currently the chair of the Mississippi Trauma Advisory Committee and of the Mississippi State Department of Health. So fantastic stuff. Dr. Donald, and of course you do work with a very unique person in this position. How has your perception of HIM and the coding and CDI leadership changed over the years, and especially since you've become a physician champion?
Well, I think first I'd like to say I appreciate the opportunity to be present and to be participating in this panel. Thank you for the opportunity. And I think having gone from a era of physicians who documented traditionally on paper and wrote very little, something a 3-line note was fairly common for most surgeons, 15 or 20 years ago, to where we are now with the electronic record. I think that's been in some instances, that's been a transition for a lot of physicians. It's been a difficult transition to make, and trying to get physicians on board with documenting a lot of the subtleties of the medical care and understanding the impact that it has, particularly on reimbursement. I think that's where you get the most bang for your buck in terms of educating your physicians on how that can impact not only reimbursement, but also things like quality ratings for your hospital, as well as quality ratings for the individual physician. So I think that type of education has been eye-opening for me, and that's kind of where I've come from and been able to kind of better understand what the importance is of making sure we have this accurate documentation.
What does your kind of administrative team do to leverage your work as a champion? And what do you rely on to make your job more effective?
Well, I think what I rely on primarily is feedback. Certainly it helps to get some feedback to say, yes, this was good documentation, this is helpful here, or, no, this, needs some improvement here. You need to specify a little bit better or expand on this thing that you've mentioned here in the chart, that this is something that needs a little bit further discussion or further clarification of a diagnosis. I think that with the opportunity, especially, dealing with so many patients here, and primarily the attendees here from Georgia, so many of our Deep South patients have so many medical comorbidities that we don't take advantage of. Things like morbid obesity. Such a big percentage of our population has morbid obesity, and often that's not documented accurately, or they have diabetic complications that are not documented accurately, or they have simple things like this, a history of drug or alcohol use that we don't document accurately. Those things that are all complicating your care, and that certainly we're addressing on the clinical end, but we don't do necessarily a good job of documenting those completely.
Yep, thank you. And kind of to tie in, Lorie, can you talk about how you've used your advisors to improve payment for clinical services?
Sure. So we actually have used our physician advisors in when we have problem cases that we need some clarification on, just from a clinical standpoint, we will use our physician advisors to explain it to us. Hey, explain this to me so I'll understand better how to code it, and to get that accurate ICD-10 code that we need, or an accurate PCS code. We also use a physician advisors through a vendor source, FairCode. We use those that they do pre-bill DRG reviews for us, and so we use those, and they give us feedback on recommendations on what we need to change, or what we need to query on that maybe we missed. So it's very important. I use my physician advisors a lot, and I see somebody ask the question, do we have specific PAs, or do just any MD? I do have some specific MDs. Dr. Stogner and Dr. Donald both are specific to my organization, and people know they are physician champions. But I also look at, is there another provider that may have a relationship with the physician I'm having trouble with, and can I get him to talk to them, or can I leverage them to go about it another way? We go through all kind of different tactics to get what we need. And yes, we do have specific physician advisors, but we also take advantage of those that are not necessarily designated as a physician advisor.
Thank you. And that definition, I had intended to do that at the beginning. Of course, there's the physician advisors at the hospital that are still practicing and or in this role to help influence. And then there's outsourced vendors like a FairCode, and there's others in the market that either use physicians to direct their CDI teams, or in FairCode's situation, they actually have physicians doing the chart reviews, providing that data and feedback back to the physician champions on staff. So there's kind of a lot of ways to define that term, physician advisor or champion. And there's a lot of different ways they can approach what they're looking at and what they're looking for. I know Lisa had given a couple examples earlier, but can you tell us a little bit, Lisa, of how you've used physician advisors to plan for clinical services?
I think it's really important for the physician advisors at a hospital to get involved when you have a new service line. So if you're contemplating, bringing on a new spine program, or you're bringing on a new cardiac program, engaging with that medical staff is very, very important. Lorie, for example, did a project where she worked with her neonatologists and pediatricians. And maybe, Lorie, I'll just hand the ball back to you.
Yeah, I was thinking, I didn't really answer that question Tom asked me. I got sidetracked to the other question, but yes. So we had a NICU project where we give a very expensive formula fortifier, and we were not really making the money that we needed to make to cover the cost of that formula fortifier. So what I did is I sent a 13 chart audit to a pediatrician that works for FairCode, and they went through and audited. And we found that there was a very specific diagnosis related to premature babies that caused our risk of illness to increase and our risk of mortality to increase greatly. One of those particular charts had a $50,000 return on it if we would have used that diagnosis. Now, these are older charts, so we were not able to go back and rebuild because they were outside of the filing time frame. But we were able to educate our NICU physicians by bringing on the FairCode physician. They did a Zoom call, and so our physicians have started documenting that. But not only did we identify the diagnosis, FairCode helped us build the clinical criteria that we would use in our facility to be able to assign that diagnosis. So that made it very clear cut for my CDI. They looked at the parameters, and if that baby met that, then we were able to query for it if the physician had not already documented it. And I believe that the diagnosis was late metabolic acidosis in a newborn. And to be honest, none of the physicians really knew that much about it. The only paper published on it was back in the late 70s. So it was not anything that had been really developed, and it is held up. Even under review from Medicaid services, they've allowed that diagnosis to stand.
Mm-hmm. And we did a similar study with a large academic medical center it has an affiliated children's hospital here in the South. And what we were asked to do was review 100% of their normal newborns for an entire year. And the idea was, or what prompted the study was the neonatologist kept saying, we have babies in our normal newborn nursery that are not so normal. And they take more nursing care, it takes more lab monitoring, and it's not showing up in the severity and acuity of our normal newborns. And so what this academic medical center tasked us with was review 100% of our charts. We have two missions. One, we want to make sure we're getting adequate reimbursement for these not so normal newborns, but also we are interested in establishing a level 2 nursery so that we can put these not so normal newborns into that nursery and then right size the staffing for that unit. By us looking at 100% of the charts, it helped them size that unit. So then when they went to get their CON from the state was able to see that they had validated that we have a population here at this academic medical center as X, and then we could support that CON. They got the CON, and then they were able to segregate those babies. Then the next step was they went back to their payers, including the state, and said, okay, we now have a level 2 nursery. Here's what we want to do to set rates so that we're not paid at the normal newborn rate, but we're paid at that at a different rate for our level 2 cases. So it was a long-term approach, but by keeping an eye on what we needed to do from a physician perspective, we were able to establish the acuity of those cases and then start the ball rolling with the CON and the contracting down the road.
I love that example. Thank you for sharing.
Sure.
It's, you know, when you use your imagination of using a resource like a physician that also has that coding and kind of data focus, it really is interesting.
Mm-hmm.
Dr. Stogner, geez, the pandemic has really caused people to react and move quickly. In the ICU, you're accustomed to quickly changing scenarios. How has COVID changed your role, and how are you leveraging the EHR?
Yeah, definitely. The pandemic is, it's been a stress on everyone, everywhere, not only in the ICU, but throughout the hospital, just from the volumes. And of course, an increased workload for all the staff, doctors, everybody. And, you know, and certainly there's an emotional stress that comes along with it. With these, when we first started dealing with it, we didn't know that much about it, who could get it, what happened if you did get it. Basically a highly infectious setting with every patient that you went to. And certainly at first, having little to offer except standard therapy for other diseases using it, you know, that was stressful in itself. In other words, what do you do about this? So it put a lot on the doctors, it put a lot on respiratory nursing, everybody involved. We've become more comfortable, obviously, with the care, with new therapies, et cetera, and learned a lot about it. But main thing now, of course, is the strain of resources, primarily staffing. And then, of course, the people that are here, it's to their limit. I say that because of by developing an implementation of you know, everything from additional order sets and protocols, that's proved really advantageous for us in dealing with the pandemic. Review care protocols, standing orders, medication management, all of these things in the electronic health record improve the efficiency of all of the staff, from the doctors and all. For instance, protocols for managing ARDS in these patients, intubation protocols, things you never thought about that you can use the electronic health record to help not only get everybody on board doing the same thing in the best way, but improve the delivery of the quality patient care. And a lot of these protocols in the electronic health record, of course, by the way they're set up, we developed such that, you know, your documentation is automatic. When the physician documents a procedure or a note and specific to that diagnosis, the documentation that's required is there. And this, of course, frees them up from having to do additional, what I would call unnecessary documentation, where things are protocolized in the electronic health record.
Dr.
So,
Stogner,
yes.
How did you engage the medical staff to create those protocols?
Well, I'm very blessed with some very innovative docs, I'll say that. The hospitalist service, the trauma surgeons, the emergency department, and the critical care service here. I would have to first of all say that they're very receptive, and I understand your question, because many times you don't find that to be the case. It has a lot to do with the leadership. It has a lot to do to leadership, for instance, with Lorie, in other words, showing us how necessary it is for us to be able to capture the coding properly for the things we mentioned earlier, not only for metrics performance, but also reimbursement. So that's one big thing. But I'll tell you that physician champions, advisors, that kind of thing, who take interest in this, and we have it on, you know, like you got Dr. Donald, you got those in the emergency department, and you have us up here that are actually do this one-on-one. I learned from Lorie's department, in other words, what's needed to be done. And on the front end, I show the docs, look, you can make yourself less work and headache and follow up if this is done on the front end. It's automatic. You do it over and over. Why do you want to write the same thing over and over or type the same thing over and over when you can have it on a protocol? That protocol, for instance, whether it's a pneumonia or ARDS or, you know, whatever the procedure is, bronchoscopy, you do it on the front end, it's all done. That protocol and the electronic health record then, of course, is associated with the orders, with the orders, but also what has to be done as far as nursing, respiratory, et cetera. So the doctors see the benefit. If I click on the buttons and then make the necessary changes based on the individual patient situation, you're freeing up my time. It's better.
Yeah.
I have to jump in here. I don't really think he tells them it saves them time on the front end. He probably tells them those pesky CDI people will not send you queries if you do this the first time.
That's right. I tell them you won't have to provide any answers for the queries.
And then I have to admit, there is also amongst doctors and nurses and physician extenders, there's a perverse sense of competition. You know, I've got the sickest patient. Oh, no, I've got the sickest patient. Well, my patient is in ARDS on, you know, pulmonary vasodilators, continuous dialysis, and 3 pressors. Well, my patient was took a drug overdose and set the house on fire and then stabbed herself in the abdomen 5 times. You know, so there is some perverse competition within the healthcare realm about people wanting to say that they are taking care of the worst of the worst. So I think
Sure.
that is a help. It helps out with some of the documentation too.
Sure
Let me
does.
show you that how sick my patients are.
Yeah. I know I'm changing the subject a little bit, and maybe there's some list takers out there, but from our studies, we found that those consensus statements, those protocols, those clinical criteria around, I'm going to give you a list: sepsis, acute respiratory failure, post-op ileus, acute kidney injury, acute encephalopathy, morbid obesity, just like Dr. Stogner suggested, CVA TIAs, post-op respiratory failure. Those are really big hot buttons for our payers, and having what Dr. Stogner has talked about, having those criteria in place, those protocols in place for those key diagnoses will really help reduce the number of denials based on coding.
Right.
Now, one of the hot buttons that has come out from the OIG, maybe y'all are aware of it, but severe malnutrition is now on the map. And so having your physicians engage around the topic of severe malnutrition, creating those clinical criteria, creating the treatment plans. If your dietitian is documenting severe malnutrition and your medical staff keeps that patient on a regular diet, then that doctor hasn't done what they need to do to address the severe malnutrition, because no payer in their right mind is going to pay you for severe malnutrition if you still got the patient on a regular diet.
Right.
So those kinds of topics are very, very important to engage your physician advisor in to help reduce those denials and get that documentation on the chart. By having local consensus statements that are embraced by the medical staff, allow you a much stronger argument if you're going to appeal those denials as well.
Right. Hey, I want to jump in here and talk about, you're talking about the consensus statement. So what we have done in our department is develop what we call pocket cards. It's a laminated sheet of paper that has all of the information they need for documenting specific diagnosis, and the whys and rules and sort of, but it's all in short comments, it fits in their coat pocket, and our physicians use that. And I can say Dr. Donald uses it because we were in a meeting with the president of our hospital one day, and he was kind of questioning some things in the education we were doing, and Dr. Donald whips out his pocket cards and shows him, see, we have these, they've made these for us. And
I've got them in my pocket right now.
Right,
I've got it right with me.
so he kind of got me out of hot water, even though we hadn't done anything wrong. The president was just questioning, what are you guys doing? And when he whipped those cards out, I could have just stood up and cheered because I was happy, so happy.
Well, still, even if you have all of that in place, there's no guarantees some payer isn't going to deny something.
That's true.
But it sure makes it a lot easier when you've inoculated those charts with that kind of rich documentation, so
Right.
that you can just bring it back up to the payer and say, hey, let's talk about it.
Right.
Let's think about this in a little differently.
And as Dr. Stogner was alluding to with some of the protocols and really with the electronic record, having a template that specifies some of those trigger points that's needed for, certain issues to be mentioned in your note, that, it's kind of a reminder. Hey, if this patient have this comorbidity, be sure and, it's that trigger in the template to document that appropriately.
Mm-hmm.
Mm-hmm.
So Tom, you had some case studies you were going to bring up. We've got about 15 more minutes.
Yeah, thank you, Lisa. It is such a critical time in healthcare with the financial ramifications from COVID, and not that it was all that easy a year ago, but it's really difficult now. So whether you're using internal staff or you're using a vendor, I'm going to try to at least show some examples of financially what a program of, really programmatically reviewing DRGs before a bill is dropped, what it can mean. And okay, this just says it all. You should be able to tell this immediately. Now, let me focus in here. So this is Forrest General's results for their lifetime with FairCode. So this is about 4.5 years. And to make it a little easier, so we reviewed 37,000 charts, or about 32% of their discharges. So again, we're saying not looking at just a very small subset and trying to infer opportunities out of that. We're really saying these problems come up over and over despite the education, despite the reinforcement. So 32% of the discharges, we made recommendations on 15% of the cases we looked at, and they accepted 80% of our recommendations. Financially, what that meant was an additional $12.8 million in reimbursement. And we decreased. So, when you're reviewing charts, sometimes you're going to find an opportunity for higher weighted case or lower weighted. So in this case, there was 1.1 million that they brought the case weight down. That resulted in a 4.84 to 1 gross ROI. We've got a lot of smart finance people out there. ROI is incredibly important, but I think it's really the total dollars. So we could review, Lorie could say, instead of reviewing 32% of our discharges, let's review 5%. I bet we'd get a 10 to 1 return on investment, but we wouldn't get the total contribution. So taking out FairCode's cost, taking out those lower weighted recommendations that were accepted, they bottom line 9.2 million over this time period. So really, really strong results, and great job, Lorie, for leading that program. And interesting, so the change in principal diagnosis, there's a lot of folks and there's a lot of history of CC and MCC capture is kind of the primary goal of CDI or vendors doing a DRG validation. By employing a physician in this role, we're really getting into the nuts and bolts of the patient story, and we're helping find the hidden truth. And in this case, 52% of the accepted recommendations were a change in principal diagnosis. So we're really getting the patient in the right bucket. that helps the reimbursement. It also helps your quality scores.
Hey, Tom, I want to interject here when you're talking about the change in principal diagnosis. Some of them are probably looking at that and going, oh my gosh, you must have terrible coders. But that's not the case. I actually have had numerous vendors and outsources tell me that I have one of the strongest coding and CDI teams they've ever seen. The problem is when you have these patients, these really sick patients that come in and they have multiple diagnoses, from a clinical standpoint, sometimes one may outweigh the other, and the physician is better to tell us that than the coder making that decision. We do make the decision, but a lot of times that physician can go in and clinically say that was not the appropriate one. Let's use this one. They both count as a principal diagnosis, but I think this one had a little more weight behind it. So it's not that it's a bad coding team. It's that there are clinical factors we're looking at from a physician standpoint that helps make those changes.
Thank you for saying that. You're so right. And in addition, the addition of secondary diagnosis is going to help that denial prevention as well. So, and yes, we have so many customers that have really strong coding and CDI programs, and these are fairly typical results. So what does that mean now? FairCode and again other vendors, and you could frame an internal program to focus on quality. And actually, I saw an ACDIS survey recently that 70% of the systems were doing some kind of quality focused validation, which is great. But this is based on our, FairCode uses analytics and over, a huge database of cases that they've looked at to target from a financial perspective, the change. So that being said, by changing, by making those small percentage of recommendations that get accepted, it still impacts some of the quality scores. So here's a good example. You can see that the 37,000 cases reviewed, the pre-FairCode versus the post-FairCode, the change in expected length of stay increased 3%. Now that's on 37,000 cases. Now on this much smaller subset of those cases that were actually recommended and then accepted, that was almost 27% change. And of course, the ratio of observed versus expected, similar numbers, but especially on the accepted cases, 21.2%. So it's kind of cool that we found all these dollars and that was really kind of the focus, but yet there's this inherent impact to quality that comes from a program like this. Here's another hospital. This is a 1-year sample of data. This is a 1,000-bed academic. And again, to Lorie's point, this is basically a single building with 23 nurse CDIs and 14 physician advisors on their staff. And yet a program, looking at what we look at, only about 10% of their discharges, but that was 26,000 charts over the year, recommended on 10%, accepted 61%. So definitely we're recommending a little less here. Their acceptance rate is a little bit lower, but yet the financial outcome turned into a 5.1 to 1. There was $1.1 million included in that in denial prevention. And geez, a $7 million bottom line over a year, yet with all those internal resources is pretty telling. And they had a change in principal diagnosis of only 36%. So as you can see, another example, 210-bed hospital, much smaller size hospital, 1-year time period. But yet they're having us really review almost 50% of their discharges. So they've kind of really pushed in a little bit stronger. Recommendations on 21%, that's a little bit higher than you saw with the other two, but accepted 67%, right about at our, we call it a benchmark, but it's really just our average rate of all customer. accepted cases. You can kind of read through this. And a net for 1 year of just over $1 million for a 210 bed hospital. So those are dollars that really mean something. There's not a lot of extra effort. You know, we're only making recommendations on 21% of the cases we're looking at. So it's not a big extra lift, I guess, at the hospital level. And in this case, 37% change in principal diagnosis. We can certainly open that up to questions at the end. I suspect there may be some. But this was interesting. And Lisa, I'm going to let you explain this, but you might ask, how did the COVID pandemic change kind of our work or specific DRG? So take it away.
So this was a study where we looked at the DRGs for the period of April to November of 2019 versus April to November of 2020, thus taking into accountability any seasonality in those numbers. DRG 177 to 179 are your respiratory infections. These are your Dr. Stogner and Dr. Donald's cases. Then you have the cohort in your NICU of 791 to 793. Those are your premature babies in your NICU. Your 974s and 976s are your HIV cases, and then 870 to 872, which is really where the bulk of your COVID patients are in the ICU, and that's in the septicemia and severe sepsis categories. And essentially what this graph is showing that, you know, the DRGs that were traditionally overcoded pre-COVID are even more overcoded during the COVID period. And likewise, those that were undercoded pre-COVID are now even more valuable from a revenue standpoint to an institution. So this is a real area of opportunity to look at your COVID cases that are being reported out to the feds and to the state and to your commercial payers, of course, and look carefully at those DRGs. Now, looking at the time, we probably ought to move along.
Yes. Wow, that hour went fairly quickly, but
it did.
Just to close before we get to Q&A, especially our guests, Dr. Stogner, Dr. Donald, and Lorie, any final kind of thoughts you have on this topic that you'd like to share?
I would just like to say that I think most physicians are willing to help and willing to go back and revise charts as needed. It just simply takes some education on the part of the physician as to what the goal is. They emphasize that at the beginning. If you can emphasize to your physician, here's what we're trying to achieve, you know, whether it's for quality purposes or reimbursement purposes. I think that many physicians, once they understand the goal, they're certainly more receptive to making the appropriate documentation as needed.
And we found that to be the case, especially here at Forrest Health. We don't get a lot of pushback when we go to providers, but I think a lot of that goes back to we've developed those relationships with them and they trust what we have to say. So there's a few that do give us pushback, but most of the time we can discuss it and have a conversation about it, and they come around.
So somebody in the audience has asked, can you explain the negative dollar DRGs? And this is, I think that question is relative to the slide that's on your screen. So on your 793s, those are your NICU babies. Anytime we find cases that are overcoded, typically speaking, that is a diagnosis that may have been carried forward as something gets ruled out. Unfortunately, with electronic health records, we often see conditions carried forward. So you'll find that a diagnosis gets picked up by coding, but there's no clinical support for it. There are no clinical indicators for it. And so when our physicians review it, historically, we tell the hospital, no, there just isn't enough data to support that particular diagnosis. I'm sure we can go into great detail about note bloat and how if you have physicians cutting and pasting and moving those problem lists going forward, that you're going to end up with a lot of diagnoses that are unsupported because they've been ruled out, or you'll have diagnoses that are from a previous admission or a previous encounter, but are no longer important today in today's case. So I'm sure Lorie could go on and on about problem lists and use of problem lists, but that's usually where there's a big area of opportunity. In the case of 870, that's in the field of sepsis. Sepsis is a diagnosis that has been unfortunately overused in a lot of cases. And so what we're looking at when we're looking at it is, was there really a case of sepsis? Was the patient sick enough? Were they toxic enough? Was there systemic involvement? And even though a diagnosis may have been picked up for sepsis, it just wasn't clinically supported. And that's why in 870, in the case of 870, we end up reversing it and recommending a lower case weight on those two. I hope that answers your question, Mel.
And Lorie, I know you're going, Lorie from Georgia HFMA, we're going to have to wrap things up. I do want to encourage, if anyone out there has questions beyond this, please feel free to contact me, Tom at alliancehim.com. We really do appreciate you joining. And Lorie Heavey, if you want to close us out or see if there's any other questions that we need to open up to, we're certainly happy to stick on a few more minutes.
Sure.
Yeah.
Happy to do that. Yeah, I did capture all the questions that are in the chat here. So Tom, I'll send those over to you. There were maybe one or two that we didn't get to today. We do have to conclude. So thank you all for participating in today's webinar. And thank you again to our panelists for sharing your expertise. It was a lot of great dialogue going back and forth with everybody. We'll pick up again for the Georgia HFMA webinar series on January 13th. And actually that will be our first HFMA Region 5 webinar day. That'll be January 13th. We'll have 5 education sessions running throughout the day. You'll receive a save the date email coming soon. Again, just as a reminder, everyone will receive the recording and presentation from today's session. I'll be sending that out on Friday, along with an email for your continuing education credit certificate. Thanks again, everybody. As we close out the year, I think we're all hopeful for the promise of vaccines and treatment, so we can begin to see the light at the end of the COVID tunnel. I hope you and your family stay safe and are able to find time for peace and recharging your batteries. You've definitely earned it. Thank you so much, everybody. Best wishes for the holiday season. This concludes today's session.
Thank you.
Thank you. Bye.
Thank you.
Bye-bye.
Bye-bye.
Thank you.